This week, we welcome Josh Corman to talk about the state of healthcare security and possibly another very special guest. In our listener feedback segment, we're going to talk about data security, either on-premise or in the cloud, and the merits of each. In our stories of the week, a new take on the Rowhammer attack, and Dropbox announces 68 million credentials were leaked online in 2012. All that and more, so stay tuned. This is a Security Weekly production. Broadcasting live from G-Unit Studios in Rhode Island, it's the show where exploits run wild, packets aren't the only things getting sniffed, and the cocktails flow steady. It's Paul's Security Weekly. Security Weekly is brought to you by the SANS Institute, the most trusted source for computer security training, certification, and research. Visit SANS.org to explore the full curriculum and latest training offerings. Onapsis, the leading provider of solutions to protect ERP systems from cyber attacks. Customers can secure their SAP and Oracle business-critical platforms from espionage, sabotage, and financial fraud risks. Visit them on the web at onapsis.com. Pony Express. Check out their line of penetration testing devices, including the Pwn Pad, the Pwn Phone, and the Pwn Pro. For enterprises, there's Pwn Pulse, providing continuous visibility into wired, Wi-Fi, and Bluetooth spectrums across all physical locations, including remote sites and branch offices. For all those hard-to-reach places, there's Pony Express. Visit them on the web at ponyexpress.com. Welcome, everyone, to Security Weekly. This is episode 479, and it is, in fact, September 1st, 2016. I'm your host, Paul Asadorian, broadcasting live from G-Unit Studios in Rhode Island. Flying solo tonight here in studio. However, on the lines via Skype, we've got Mr. Joff Thayer. Joff, welcome to the show.
G'day, Paul. How are you? Good to be here for another fine Thursday evening.
We've got Mr. Jeff Mann with us as well.
Hey, this is my Skype debut on Security.
You're popping your Skype cherry, so to speak, Jeff.
I am.
It was so weird to hear you in my headphones because you've only ever done the show in studio. And all of a sudden, Jeff starts talking, and that was weird. And we do have a very special guest. Katie Mazuris is here. Katie, welcome to the show. I am so excited you're here. Yay.
Hi. You mean welcome back. I've been on your show before.
You've been on our show twice, at least, before. Yes.
At least.
Yes. It's nice to have you back, Katie. Josh Corman's here with us as well. Welcome, Josh.
Hi.
I'm excited to have you on too, Josh. Just not as excited as I am.
Just not as excited.
You know how it goes. Just a couple of quick announcements before we get started. I want to mention a webcast that we're doing, securityweekly.com/hot seat. We do a webcast series called the Enterprise Security Hot Seat. We take a product specialist from a security vendor, and we put them in the hot seat. We ask them 10 questions, and they're hard questions. They're not easy questions about the products. On September 13th at 2 p.m. Eastern Time, Yolanda Smith, the Director of Product Management with Pony Express, will dig into the number, types, and ownership of devices showing up on enterprise networks and how you can protect them. We'll also get in some cool tech for monitoring and securing your enterprise from wireless, Bluetooth, and cellular, and even good old-fashioned wired device threats. You can register for that webcast at securityweekly.com/hot seat. Just a reminder, visit securityweekly.com/subscribe to subscribe to all of our shows, Enterprise Security Weekly, Startup Security Weekly, and Hack Naked TV, as well as this show. I do want to announce, because some people have been asking, hey, I'm subscribed to them, we call the main feed, but I really just want to feed with Security Weekly and all the other individual shows. All that is available. The problem was the Security Weekly podcast only feed wasn't in iTunes or Google Play. That happened today. Well, I got approval for it today. It may take another day or two before it actually shows up in iTunes or Google Play. So if you want to
I thought,
subscribe
Paul, they
individually.
were asking, is there any way that we can mute out Paul's feed and just do the Hack Naked News?
Pretty much. I think there's an underlying agenda there. So
That's right.
So as I said, Josh Corman. Let me go to Katie. Katie, I want you to introduce yourself. Talk a little bit about like where you are today and what you're doing.
Sure, thank you. Katie Masouras. I am the founder and CEO of a new security startup company called Luta Security, and it is named for the island where my mom was born in the Northern Mariana Islands. What we do is we help governments and complex organizations work with hackers more productively, namely in the form of vulnerability disclosure programs and bug bounties.
Katie, you have a security startup. We have to have you on Startup Security Weekly. You're going to have to
All
make
right.
another appearance. How's that?
Excellent. That sounds like a good deal.
Awesome. Josh, why don't you give our listeners an update as to what you've been up to lately?
Hi, Josh Corman. I'm one of the founders of IamTheCavalry.org, focused on public safety and human life in the Internet of Everything, too many things. And in April, I left the private sector, and I'm at an international policy think tank. I'm the director of Cyber Statecraft for the Atlantic Council.
I've asked Josh and Katie to come on the show today, who've both been on the show several times before, to talk about the state of healthcare security. And let me set the stage, and hopefully this is the longest that I actually talk during this segment. I want Katie and Josh to do way more talking than I will in this segment. My wife and I had a baby. Well, my wife delivered our baby on June 7th of this year. And we kind of had this debate as she was going into labor. Now, she was obviously distracted during that time. I somehow convinced her to allow me, or she, I guess, I went against her better judgment. And I was tweeting and using social media, relaying information to my followers and subscribers about the birthing experience that we were having, which she was like, no social media. And I sent out some tweets, and I'm like, we're really trending on Twitter. You sure you want to do this? And then the cat was out of the bag, so I started tweeting. One of the tweets that I made, which was the day before my son was born on June 6th of this year, my tweet exactly was, at hospital now with wife in labor, looking at monitor, and she says, see the baby's heartbeat? And I say, is that Windows 98? And now, what's interesting was I didn't really think much of it. I was like, "Oh, that's kind of a funny tweet." I thought it was funny. My wife tends to not think I'm funny. Some people think I'm funny. I thought it was funny, but lo and behold, like through the whole birthing process, this tweet is getting massive amounts of attention. And she's like, "Are you still on your phone? Like I'm getting ready to push." I'm like, "We're trending on Twitter's tweet. This is awesome," which didn't go over too well, but. In the end, as it stands today, September 1st, and I have seen even in the past couple of weeks, people still favoriting and retweeting this tweet. It has 1,231 retweets and 2,069 likes on Twitter. By far my most popular tweet that I've ever made. Now, some of the responses were of congratulations, and I thank my followers for that. I think June 7th puts my baby at around 12 weeks or so. I don't know. I suck at math, but he's around 12 weeks. He's awesome, by the way. Very smiley, happy, healthy baby. But a lot of the tweets were, yeah, I noticed the same thing. Or I noticed the same thing about healthcare. And the state of healthcare security is really, really poor, and this is a huge problem. And I'm listening to all of this, as I'm walking around a hospital and noticing the things that security people notice at hospitals, unattended stations, Windows XP, and those kind of open Wi-Fi networks, the whole thing. And I talked about this experience on the show over the summer, and I mentioned that I wanted to do a segment on the state of healthcare security because I really wanted to delve into the solutions. What can we do, and what are we doing to fix the problem? Because obviously, as is evidenced by my tweet, there is a problem. I got tons and tons of email of people saying, oh, I'll come on and talk, and you should have this person, and I would love to have everyone on the show. However, as it ended up, I have Katie Masouras and Josh Corman on the show to help us talk about the state of healthcare security. So given the context of the tweet, I guess start with some of the usage of legacy operating systems in healthcare organizations. why that's the case, and what can we do, and what are we doing as a community to help improve this security problem?
Simple problems, right?
It's easy, right? Just replace it, right?
Well, first of all, the context of your tweet, I just have to put this in perspective for your listeners. Over 1,000 retweets, that is probably about 3 times the number of retweets that I got for the tweet that I sent announcing the Microsoft bug bounty programs about 3 years ago. So just so you know, contextually, your observation of, older operating system while your wife was delivering the baby, much more significant to the world than Microsoft paying hackers money for the first time. So
It's
just wanted
interesting,
to-
right? Like, that was just a funny thing, and look at the traction it got. So I'm glad we're here
Well-
today talking about it.
And I'm glad we're talking about that tweet, Paul, and not the one with the picture of your backyard saying this is where it all started, which I
It
took
did.
totally out of context.
My wife was wearing her leopard pajamas, no bra, and clogs, and mowed the grass, which is what induced labor, in case anyone was wondering that. In any case, Katie, continue.
Anyway, go ahead.
No, but I mean, what you're describing there in terms of what you observed is it's not, we're talking about it in context of the medical and healthcare state of security and outdated operating systems or unpatched systems. That's actually a problem in a lot of different areas. So the vertical you're concentrating on is healthcare, certainly significant, but essentially anything that has specialized equipment that runs on an older operating system, you are going to run into organizations like a hospital in this case that are unwilling or unable to patch because the manufacturer of whatever it is that it's running is unable to keep up with the patching cycles of the operating system manufacturer. So it's a common deployment problem that we see in the ecosystem. And certainly when I worked at Microsoft, there was a whole bunch of enlightening conversations that I had with, for example, mining companies who were going to run Windows XP well past its expiration point because XP was the only thing that ran their smelting equipment. Their smelting equipment had to run for 50 years. So that, you see this pattern all across anywhere where there's some specialized equipment and you've got a manufacturer that's relying on a particular version of an operating system. So healthcare is not unique in that sense, and we've got a pervasive problem with that in general. With that, I'm going to let Josh go ahead and wax philosophical. About
Just to say something before Josh speaks, share like a personal detail about our birthing experience that I didn't share on social media that really speaks to the importance of this issue. At one point during our birthing process, the baby's heartbeat slowed down, so much so that there was paperwork being brought out to go in and basically get the baby via C-section. It turns out that everything worked out, and they were able to return things to normal, and we had a natural birth and a very healthy baby. However, that underscores the importance of this particular technology in the medical profession, and I experienced that firsthand. I mean, that was a horrifying moment, very, very scary. But it's not, and my point is, it's not something that we can just go change today. Like, we change technology here in the studio all the time. We do a podcast. We're not monitoring, unborn babies' heartbeats with the technology we have here. So I think it puts kind of a different light on this issue.
And there's a lot of aspects to this, and we can drill into any or all of them. One of the ones that we tried to tackle first with the Food and Drug Administration was the minimum criteria or guidance for cybersecurity. I know I'm saying cyber on this, but that's the words that they use. So for today, we're gonna use them. I'll have to drink. Oh well.
I think we'll all drink.
We'll all drink today.
So
Cyber.
one of the ones we have to look at is there was really prior to 2 years ago.
I'm just going to hit the mini bar then. I'll be right back. I'll get a drink.
There you
Okay,
go.
I'll be right back.
Yeah.
Okay.
So this is not an excuse at all. I'm very disturbed by what I'm about to say. But prior to 2 years ago, there was really no guidance for cybersecurity standards for any medical device approval at all. And you had early researchers like Dr. Kevin Fu, like Barnes, like Jay Radcliffe, finding issues, trying to bring them to the manufacturers. The manufacturer didn't know what to do about it. FDA didn't know what to do about it. There's a lot of fear and denial, and like Katie's 5 stages of vulnerability disclosure grief. They've kind of gotten over that hump of fear and denial and panic, and over the last 2 years, they've introduced guidance in a couple forms. The FDA has pre-market guidance for connected medical devices that tell you the things you have to do before you can bring a new product to market. And this past January, they put out their post-market guidance, which is the expectations for ongoing care, feeding, and hygiene of the cybersecurity concerns of these devices. So you had this long period before 2 years ago of an adversarial relationship between researchers and device makers who didn't do threat modeling, made really bad designs, and a lot of those really bad designs are in the market still and will be for quite some time. We're trying to now set the bar and clarify expectations, and the stuff that's going through R&D right now is getting better. And it still won't be as good as we want it for a while, but I think we're doing a decent job on the devices themselves. The second issue, though, which you're touching on, is bigger. And in Congress in December passed the CISA Act of 2015, and one of the parts of that was they attached a requirement for a task force for Health and Human Services for cybersecurity. And they named 20 people to that, and I'm representing the research community for that effort, and that's their deep concern that the average clinical medical environment is unsafe at any speed, essentially. They know that after this past spring, that piece of ransomware from SamSam that exploited a known vulnerability in JBoss took out a whole bunch of hospitals, but one of them didn't pay the ransom in time at Hollywood Presbyterian, and it shut down patient care to the point where they had to divert ambulances to other facilities and consider moving patients, including critical care patients. Wow. So it's kind of like The Big Short, where you have this subprime mortgage crisis coming. We are way in debt and way upside down in our mortgages. We bought a lot of technology and deployed it, and we can't really afford to safely and securely operate it in these clinical environments. But you don't want to panic everybody. You can't afford to forklift upgrade and replace all that capital expenditure. There's a real workforce shortage. So we've got 6 things we have to bring back to Congress after a 1-year task force. We're about halfway through. And of all the topics we're covering, this particular one about Windows 98, Windows NT, Windows XP in the clinical environment is the one that's scaring the task force the most.
So, Josh, you made a comparison between the state of healthcare security to basically the stock market and property and realty crash of 2008.
Yeah.
As a result of that crash in 2008, the government had to step in and bail out many of the financial organizations. Do you foresee a similar situation where the government kind of bails out the medical, clinical implementations as you stated them,
or a variation on that? What would a bailout look like
for that? Right,
in the healthcare industry?
Yeah, it would be interesting.
Well, there's a lot of aspects to it. I mean, one that gets a lot of airtime is all the legacy equipment. But to Katie's point, there's a lot of environments that have to use legacy for a long, long time. One of the issues I shouldn't have blitzed past is there's a real strategic workforce shortage for qualified security people that work in healthcare. So the average number of security professionals in a small and medium hospital is 0. They can either get a security person or a nurse or a surgeon. They can either buy a firewall or an ambulance. And it's not excusing the problem. It's just the way they've approached budgeting and staffing. They're oriented around biology and chemistry, not IT and IT security. There's another.
I just want to talk about that point for a second, Josh. I've often found that too in healthcare institutions, even some of the larger ones, major hospitals, major trauma centers, and I speak with their IT people and their security people, what little there are of them, and the security team, they're like, yeah, we have a security team. I'm like, well, that's great. Like, what do they do? And what are they seeing? They're like, well, they provision access. I'm like, so they're privileged identity management? They're like, yeah, they say who can access what, and they provision access to everyone. And because of HIPAA, they have to say that they can see this and not that, and they monitor that and they audit that. And then I'm like, well, what about threat hunting and firewalls and all SIM and all that other stuff? They're like, nah, yeah.
Well, Paul, I've tried to bring this up before when I've been on the show. We as security professionals go into this assuming that companies have a certain mindset, have a certain organizational structure, that they need to do security a certain way. But to pick up on what Katie had said earlier, a lot of industries suffer from using old technology, which we in the internet technology field, we're used to getting a refresh of everything, weeks, months, maybe a year. But she talked about the healthcare community, and there's other industries. I'm going to bring up PCI, where retailers wanted to use, they want to use cash registers for 10, 15, 20 years, not
Hmm.
refresh the cash registers, which are computers these days, every 2 or 3 years. So there's this fundamental issue of a consumer base, which is a lot of companies that are conditioned to buying things that last for 5, 10, 15, 20 years, being thrust into the appeal of the internet and computers and networking because there's so much money to be made and it's cheaper to network and use the internet as the backbone. But they're not being told, oh, by the way, you're going to have to refresh things every 1 or 2 or 3 years. You're not going to get the 15 years out of your technology that you're used to getting out of.
Yeah, if I could interject as well, we saw, and Paul, you're probably intimately familiar with this. In my career, I've seen the same issue in spades in research universities as well.
Sure.
Yeah.
Things
Yeah.
like scanning electron microscopes that are
Yes.
running, Windows NT embedded. So it's the same issue all the way up and down with these tend to be embedded systems that have dedicated purposes.
But there's a part of me that looks at from the consumer's point of view, which a lot of customers are. Why shouldn't they be able to get 10 or 15 years use out of the stuff that they invest in?
Well, Katie,
I mean,
Josh.
it's a rhetorical question, but I think it's a fair question.
Katie, you have a point I've heard you make pretty well before about if you go to get steak dinner, or I always get it wrong. Can you say it?
No, well, what I was actually going to say was
Oh,
not that.
oh.
It's about the fact that you can get that much use out of it. However, the state of security research advances, and it's not necessarily appropriate to have all of the members of an ecosystem dependent on a 15-year-old architecture of technology. There are certain mitigations that you cannot retrofit to older operating systems. You would have to actually break the applications themselves that run on top of that operating system to employ modern mitigations. That's why you upgrade operating systems. So if the idea is that you want to just be able to run 15-year-old hardware and the most modern operating system with the latest mitigations, I think that is asking quite a lot. And it's especially asking quite a lot of these end user organizations to trust that life-saving equipment, that Paul, you and your wife were using, is going to function properly when, the system that it was designed to work on, the hardware itself, is 15 years old, even if it did get upgraded. So, I mean, the entire ecosystem, it's one thing. Josh was talking about the pre-market guidance and then the post-market guidance that we both worked on together with the FDA, expecting security researchers and medical device manufacturers to coordinate vulnerabilities. Even if that happens, and even if a patch is made, deploying the patch might actually destabilize the system in unpredictable ways that would affect safety. And I think that's the whole chain of that ecosystem is really what the problem is. But Josh, you wanted me to say the line about, if you're a vendor and you are not building in enough budget to take care of residual software vulnerabilities that are reported after your device or your product is released, then you're like a person in the United States who's decided to go out to eat, but you didn't leave enough money for the tip. You didn't actually bring enough money for the tip. You probably should have stayed at home and cooked dinner yourself. But the broader point that I wanted to make is this is an ecosystem problem, and it's not just between the vendors and the researchers. This is an end-use deployment problem and how it affects safety and stability.
I think it's interesting that in the medical environment specifically, and I relate to some of my own challenges here that we have with our own technology that runs the podcast. We can't necessarily virtualize everything or put everything in the cloud and make it as hardware independent. And I believe that some of the problems in the medical field today that we have in terms of devices and security are because it has to be a physical device that comes in contact with a person, and it's very difficult to virtualize. Have Josh or Katie, you explored more ways to virtualize this technology with vendors so that we can more easily provide software patches that will go back in time, maybe not 15 years, but much longer?
Well, the thing is about that equipment, you were physically in the hospital with your wife.
Mm-hmm.
There was an end of that equipment that actually needed to, that physical hardware thing had to be there in order to interact with you in that healthcare environment. So just by nature of what we're talking about, whether it's healthcare and you need a physical device that's in proximity to the patient, or it's transportation, or it's something else, you're dealing with physical devices that can't be virtualized in that way. You could virtualize the storage of medical records and try and secure it that way, but that's not what we're talking about. We're talking about equipment that must, by design, be in close physical proximity to the patient.
Sometimes inside the patient.
Yeah,
Just
yes.
saying.
You know, I know you were going to go there, and I wasn't going to go there, so I just want your wife to know that I did not go there. Okay? That was you did that.
I wonder. I've got a question. I wonder in the work that Josh is doing, perhaps Katie as well, whether some of the recommendations that are coming out from your teams is surrounding layers of bolt-on technology, layers of additional defense that kind of put this stuff in a bubble, so to speak, to help mitigate the interim risk.
Well, I haven't told you the worst part yet. This was a controversial thing to say. It's almost like, and I know Jeff and I have argued about PCI before, but when we did the task force meeting, the very first thing I said, and if the listeners don't know what this is, I'll have to explain it a little bit, but I basically asked the question, I said, is meaningful use, quote unquote, our original sin in healthcare? And what meaningful use was when HIPAA and high-tech and the Affordable Care Act came around, we wanted to encourage device makers to start using electronic health records. And they're not very consistently done yet. But in a mad dash, to qualify for reimbursement, you had to be able to transmit electronic health records. So it essentially took a bunch of these devices that were never threat model designed, architected, or implemented to ever be connected to hostile networks. And it tied reimbursement to forcing them to slap that on there. So a lot of the issues we have is it's not like an enterprise or a bank where you can do segmentation and isolation and need to know cohorts of devices. Pretty much the reason that Hollywood Presbyterian had to deny patient care is the infection of a single health record system essentially prevented the rest of the hospital from functioning properly from way too much connectivity. So to summarize these things, you've got incentives and laws that essentially force you to be more open, kind of like a research institution like we were referring to earlier, combined with the fact that a lot of these devices are really old and they don't have the capital expenditure to redo them or maintain and update them, combined with the fact that you can't find security talent who might be able to try to do smart layered defenses and segmentation, isolation, and firewalls and all sorts of funky stuff. So the combination of those things is why things are so dire. It's
so I think
there's
more
to it.
That the combination is almost like the perfect storm of legislative approaches, albeit well intended, and the state of software, meeting the modernization of electronic transmission of records. So that's.
But we don't want to just admire the problem. One of the ideas we're pursuing through the task force and some other avenues is when I hate to use 9/11 as an example, but this is an economic point. When 9/11 happened, we spent a ton of money forming DHS. We spent a ton of money on TSA airport security, and a lot of people think it's a whole lot of civil liberties infractions in cost with very little benefit. But of all the reactions to the idea that we wanted to preserve trust in aviation and commercial aviation, one of the moves was a good common sense use of money, which was hardening the cockpit door. And what we're trying to say is instead of looking for the 10 to 15 year fix to rotate out bad medical equipment and try to work in better security talent into these environments and maybe even subsidize some of those. Bo had a great idea, I should mention too. But it's also looking for, are there some really small adjustments with some really big benefits that are readily available if this kind of an attack happens tomorrow? I mean, the scenario
that was kind of where my question was headed, actually,
right,
Josh.
Right.
So I think you pointed that out. Is there some small adjustment, even if it's not perfect from a security community perspective, that will mitigate things enough to buy us time?
Well, and what I hear Jess saying, just to, and you mentioned the word, but what you didn't want to say is that it boils down to, like so many things, it's an economic issue. So
Mm.
going back to your analogy of the the financial crisis and what's a bailout look like? I mean, it
Hmm.
might simply be how much money is the government willing to cough up to subsidize what all these healthcare companies that need to have the technology and need to upgrade it but don't have the budget for it, frankly. How much are we going to invest and be willing to invest? The potential, I think, is because I think most people can look at it and say, oh, this is more of an immediate life and death issue. Who cares if you can use your credit card, online or at a store? You go to another store. Or who cares if, something is offline for a while? It's an inconvenience. But life and death issues, yeah, that tends to get people's attention.
Well, Mr.
Hopefully.
Robach, the financial crisis is pretty dire, but um, what's the
Well,
cockpit door security look like for the healthcare industry, Josh and Katie?
Well, I'm kind of wondering about your buyout scenario. Who exactly would get the bailout money? Who exactly in this ecosystem would get it? Who do you think needs it?
So there's a couple aspects to that. Remember, I said there's the devices themselves, there's the talent shortage, and there's the legacy stuff in the clinical environment. Because a lot of these devices that got hit by ransomware, they weren't the FDA approved device. It was like an electronic payment station or a record station. So one of the ideas that was floated, I'm not saying this will work, but Bo Woods, he said, why don't we do like a cash for clunkers like we did for cars? Why don't we buy back a bunch of legacy XP systems that have modern replacements if it's a one-time capital drain? I don't think that fixes the strategic problems Katie was referring to, where some of these devices are meant to live longer. But you are seeing some of the device manufacturers change their cost structure, their R&D, and their time to live, their intended time to live, to be more realistic now that we know more. The other thing we talked about is, what if you were to give a free CISO, like subsidize a CISO for every health delivery organization, but the immediate response was, we don't have enough on the planet to do this.
So
Well,
there's
Go ahead,
Go
Katie.
ahead.
there's actually a bigger problem with that. The equipment itself is used by medical professionals who need training in how to use the equipment.
Mm.
So if you go ahead and cash for clunkers and you just turn in old equipment and have new equipment brought in, who is going to absorb the cost of training these
Mhm.
medical professionals, not security professionals or even computer end users, power users, or whatnot? These are medical professionals who have a medical job to do.
Yep.
Who is going to absorb the training cost? And that's the cost to the institution itself.
Mm-hmm.
And how is a very large organization going to deal with it at scale? How is a very small organization going to deal with it about employee redundancy and efficacy of their actual healthcare job? So, I mean, you're talking about a much more complex problem than just swap out the equipment and it'll be fine. That's not the only cost here. And we're actually in that same exact type of deal when you look at an ecosystem represented by one of the OG IoT devices, which is a phone.
High threat butt.
High threat bot had to have.
I thought you were talking
I
about the
wave this-
ecosystem of ThreatBot there for a second, Katie.
I wave this around as an example of, and someone's calling me, that's amazing. I wave this around as an example of early IoT that we still haven't figured out how to manage this ecosystem's security. And it's exactly the same type of issue.
Is that an
where we've
iPhone
got-
6 Plus, Katie?
No, it is not.
Is it
Anyway,
a Nexus 6P?
correct.
Oh,
Anyway,
you are
so
my hero. I was hoping you would say that. Love that
I've
phone.
never owned an anything, so
I love my 6P. Anyway.
right. So, but the point is, I wave this thing around at members of parliament and Congress and lawmakers all the time, mostly because I really want to wave this around. So just threat, but just know I love you. But really, I'm illustrating the problem in this ecosystem. So if you look at that as an analogy, it applies across the board to anything like this, where you've got different manufacturers across the supply chain. You've got end users. You've got, in this case, you've got carriers. So there may be some sort of a carrier model, involved in the equipment. But it's who in that chain absorbs the customer support cost if an update goes wrong? Who absorbs the training cost in training them on the new interfaces and the new equipment? All of those things add up to costs that actually affect multiple members of that ecosystem. And then ultimately, if you're looking at it in terms of healthcare, these are healthcare professionals. Their number one job is to keep you alive.
I think
So,
you laid out the parameters of the bailout you were asking about earlier.
right, but
Well,
Yeah, but do we?
And by the
I
way,
think one of the things
no
that
one's
makes,
talking about a bailout, by the way.
Yeah. Well,
Just no one
that's
assumes
why I
that
looked
that's
all
going
right.
to happen.
confused.
So let's
when
go
you said
back and
bailout.
talk about
It
a
was
bailout.
it was an analogy, Katie.
So my wife actually works in the medical field, which is ironic to this conversation and how this all got started on this podcast, actually. But to Katie's point, there is a huge cost to implementing new software. The organization my wife works for just went through a major upgrade of software, and she was telling me all the details about all of the consultants running around, all of the trainings that she had to attend, and how it was impacting everyone's ability to do their jobs, not just in the time they went to training, but the learning curve. Because even if you go to an hour, so you send all of the nurses that are on staff to an hour training, you have to do that in shifts, and then they get back and the new software gets implemented. Someone's going to have a question, or maybe 547 questions, from each person on how it works. So that's a huge cost. So my question is, for a bailout, and it was the software company that was providing the training and doing much of the implementation. Mm-hmm. Do we funnel some of the bailout money that we're talking about to the
There's
vendor?
no bailout.
But do we?
There is no bailout, Paul. There is no bailout.
If there was a bailout, would you funnel money to the software vendors to make those projects more affordable for healthcare organizations?
Paul, does your wife's organization, so they've just gone through this major capital expenditure, do they know that they need to do it again in 2 years, 3 years, maybe 5 if they're lucky? Do they know that that's something that they need to build into their budget?
They didn't before, but they're starting to.
Yeah.
Starting. I mean, it's a learning curve, and I used to tell my merchant customers, look, you talk about complaining about the cost of security and all the things that they have to do to be compliant, and I said, well, I remember the days, and I'm going to be the curmudgeonly old guy for a minute. I remember when I used to go shopping with a credit card, and the clerk would take the card, turn around, get on the phone, call an 800 number, wait for an operator, read off the credit card number, read off the amount of sale, the expiration, everything that's electronically transmitted today, wait for the authorization, write it down on the slip, and then I'm on my way. That could sometimes take 5 or 10 minutes.
That's about as long as it takes for the chip and pin.
We need to have an episode on that. That's
5 seconds
in the United States. But nowadays you go to a grocery store, a department store, you're swiping your card, dipping your card. Actually, it takes longer, like you said, with dipping. But while your merchandise is being rung up, the credit card processing is taking place. The payment processing takes place. You're on your way. So what used to take 5 to 10 minutes now takes 5 to 10 seconds. And what I used to tell my customers is, you wanted that advantage. You're moving so many more people through. You're having the opportunity to get so much more revenue. That comes at a cost. Nobody ever told you, nobody ever educated. Hi, I'm here to educate you. There's a cost for doing that, and that cost comes in the form of security and what you need to do for security, at least in part.
Everything Katie said is true. You got to add to it that they're paying a lot of unplanned money out in ransoms right now. So while Hollywood Presbyterian failed to pay the ransom and had the outage, there's a lot of money they didn't allocate to pay off ransoms. In fact, the first set of ransomware in hospitals was an accident. It wasn't targeting clinical healthcare delivery organizations. This next wave is charging more and is targeting them. And there's really no technical barriers to this working over and over and over again. The first one was a known Java deserialization flaw in JBoss in one device. You look at something Billy put out this summer. He told DHS ICS cert of one device that had over 1,400 CVEs in it. 1,400. And one of them can cause a ransomware payout or a risk to patient care. So I think everything said is true. It's just it goes into the overall total cost of, should we buy this new device? Does every device have to be connected to every other device? Do we have the staff to safely operate this device without harming patient care? And I sent a picture. Can somebody throw the picture up real quick?
Well, and while you're doing that picture, how many of those 1,400 CVEs were, these are already, the patches have been available for a long time, right?
Right.
This is
Most of
again,
them, yeah.
yeah. So this is again that problem where absorbing the cost of testing the newer versions of all of that software that goes into that device, that's something that's important, but it also, keep in mind, takes away from those engineers and testers working on the next version of that innovation technology.
Yeah.
So you've got not just the cost of the testing itself, but it's an opportunity cost that's lost in furthering innovation in medical devices and medical technology. So, as we know, we've got a labor shortage who's capable of writing secure code and testing for security vulnerabilities. Imagine, if we're forcing that limited labor pool to concentrate on fixing old versions, and keep retrofitting these patches. So there are all these trade-offs. There's sliders, essentially, in all of this in terms of the resources put out.
Are we talking pulled pork sliders or
Kobe
Kobe
do
beef
that.
sliders?
You're such a jerk. I'm going to drink now.
And I'm missing dinner. So listen, if you can put that slide back up, one of the speakers at this year's B-Sides Las Vegas Cavalry Track is an ER physician. His name's Quaddy. He speaks at DEF CON too. So I love it when you find someone who's a hacker and a physician. And he put this slide up and he said, look, we want to focus on the patients, and the technology is just a means to the end. And while it's really fun to talk about this, what he ghosted out was there's not a Hospira drug infusion pump in this room. There's 1, 2, 3, 4, 5, 6 separate drug infusion pumps to the left here, all of which have a lot of vulnerabilities and risks. And his point is any lack of trust we have in these devices affects our ability to take care of this little baby who's fighting for its life. And it's not an emotionally manipulative thing. It's that he knows his kind and his staff, if they can no longer trust these devices, they're not going to let it get in the way. There's this very strange trade-off between these devices are extending and improving health delivery, but when they become too much of a risk, they're going to start removing them and going back to less reliable, less effective things. So to Katie's sliders point, what they all are starting to realize there are trade-offs, but they don't yet have the information available to know which devices are too risky, which ones are safe enough, which ones are better than manual or paper copies. And I think the strategy you're seeing come from the Food and Drug Administration, from this task force, and from others is the current legacy devices are very vulnerable, and we need to use them for quite some time. So are there cockpit door type things we could economically introduce? But they're also, at the same time, turning the screws on future devices, so it's much harder to bring something to market that has elective attack surface. We're still going to have attack surface. We're still going to have connectivity. We're still going to have features that improve and enhance life. But there were a lot of historical choices in the design that were really stupid, reckless, and not worth it. So they're trying to really clamp down on the elective attack surface of new devices. And I think the R&D stuff is going to take about 5 years to bring better devices to market.
Well, it's interesting when you say 5 years, Josh. I think about some of my home devices and their ability to self-update, like my doorbell, or if I had the new refrigerator, which I'm waiting for my refrigerator to die so I can get the new refrigerator. But some of those devices in the home, you have an expectation as a homeowner and consumer that they're going to work for a really long time.
Durable goods, yeah.
And the certain companies are producing such devices that auto-update and have a promise that they're going to last for a really long time. Ring is a prime example. Yes, they had a vulnerability, and yes, they fixed it, and they pushed a fix out to all of their devices within 24 hours. Why hasn't the medical device community used similar technology to accomplish the same goals?
I can tell you why. Reliability.
Please do, Katie.
Yes, it's a reliability issue. Can you imagine if there was a patch that went out automatically to all affected devices and there was an error in the patch and it impeded functionality?
That
And
never
all of a sudden-
happens.
Never. Right. So
Microsoft never did that.
back to the sliders of well, now I'm hungry, but back to the trade-offs. Let's go to the word trade-off. That's not delicious at all. So the very unappetizing trade-off here is that, time to fix increases when the reliability of the patch is so important, either because it's doing an automatic update scenario where the potential for bricking one of these devices is horrendous. The actual that would be worse than necessarily paying a whole bunch of ransom. I would think everyone would agree with that. In terms of cost, because there would be direct cost to human life in that scenario. But then you've got, the time to fix extends as you have to increase your reliability to the point where an automatic update scenario would be viable in that type of environment. So that's number one. And then number two, let's say you still give the hospital administrator, the key to basically say, yes, I want to have, updates run straight from the manufacturer, straight from the vendor. Then essentially you're looking at still potentially product downtime at an inopportune time, because I'm pretty sure hospitals still work 24/7. There's not exactly a maintenance window on my heart rate monitor that I really want to have happen, in the middle of the night. And you still have these issues where, the device may be unavailable during an update window, right? So there are all these kinds of things that you have to worry about in an automated update scenario. And that's also why organizations like Microsoft have taken so long to embrace automated updates for any of their, tiers of products. And the consumer products, they've been turned on for a while. They still give the enterprises the key to be able to turn it on and off and deploy those updates at their maintenance window level. And they've started doing automated updates for the browsers in the background. But again, this is a super risky, test-heavy type of scenario.
We're not going to see an auto update, but one of the things the FDA has weighed in on in January, and this is a very controversial one, but so we'll see how they tweak it before the end of the year. But one of the myths that kept this thing stuck for so long, just so you understand the change they made, there's been a myth that you're not allowed to do a security patch without going through revalidation with the FDA. And that hasn't been true pretty much ever. So the FDA 2 years ago in July, when they put out their pre-market guidance, not only they say that you can, they say you are fully expected to patch your devices, and that a patch of strictly a security fix, as long as it doesn't change the intended use of the device, does not require revalidation. But the industry continues to perpetuate the belief that you're not allowed to patch. Well, in this January, it's very clear now what they intend, because they have a line that basically says, I'm paraphrasing, but if you have a coordinated disclosure program and you mitigate a bug reported to you within 30 days, then you don't have to go through a recall. Now, the recall is very painful. If you get a device recall, it's bad for your press, it's bad for market share, it's bad for customer satisfaction, and it's a pretty serious notification to the hospital that you really can't keep using this device. So they're trying to make a much more aggressive stand that not only, can you patch, but if you don't patch, you're going to get a recall.
So the FDA actually clarified an issue. That's interesting.
And in fact, people
sorry.
Wait, it's better. People still didn't get it after the post market. So about a month ago, they put out a flow chart that says, "Can I patch my device with?" And the answers all go to yes, except for like one little use case.
So you're saying there's a chance. That's sort of I wanted to ask a question, and that's sort of a segue. I think is the healthcare medical device industry the same as most industries, in as much as they don't do much unless they have to because of regulatory requirements? Or is there any difference there, that they're trying to be a little bit more proactive?
Well, some of them are just like any market. There's some that meet and exceed. One of the ones that we're really fond of is Philips Medical. Michael McNeil's been in the business a long time, and when we were reviewing all this post-market guidance at the January stuff, where Katie did panels and we had lots and lots of good exchange, he basically volunteered that he's going to start voluntarily publishing the software bill of materials of all the third-party and open source that he's using in his medical devices, so that when a customer like Mayo Clinic goes to buy new devices, they want to know how good is your hygiene, like how many known vulnerabilities are in this versus other comparable products. But But the better value of that is later on when there's a bash bug or a shell shock or Apache Commons collections or the SamSam ransomware, they can do a very quick impact analysis and say, am I affected and which devices are affected, instead of doing pen testing and hunting that they don't have staff for. So no one's requiring that from a regulatory perspective. But when they announce they're doing it, I know of 4 or 5 other ones that are also about to do the same thing. So you'll have a couple leaders and exemplars that realize the risks that they're introducing, and they know when you start seeing more attacks in hospitals, they want to be better prepared for that. They're not going to over-engineer the thing and be uneconomic about it. But you have leaders doing that, and other people are going to do the bare minimum and try to sneak stuff past the FDA or kind of lie on their design specs about connectivity they do or don't have. And we've seen that too.
So maybe this is a lead-in question, I don't know, but what is the regulatory standard that would address everything that we've been talking about? Is there one? Because I suspect HIPAA doesn't do it.
Well, HIPAA is all about privacy.
Mm-hmm.
Right.
We said we love our privacy. We'd like to be alive to enjoy it.
So is there
More about
is there any
confidentiality.
regulatory standards in place right now that touches on any of this within the healthcare industry, medical device industry?
They have some ISO standards they recognize, and they call this guidance versus requirements or standards. And
So that's a no.
That's a no.
Well,
Yeah. Okay.
So the interesting thing that Josh just said that I picked up on was if you patch it in 30 days, you're not
mitigate. Yeah.
What?
Mitigate.
Okay, because you said patch.
No.
And that was what I was going to ask you about. I said, wow, that's really fast. So I look at that as potentially a resource exhaustion thing for the medical device manufacturers, such that only the very large medical device manufacturers would be able to afford enough staff to stay on point and be dedicated towards doing just security stuff, versus the development and design and testing staff that's working on new products. And so essentially that has a commercial impact on innovation in the space. Again, I'm saying
Katie brings up a great point that extends into many other industries. When FDA and similar regulatory bodies get involved, it tends to be good for really large companies and bad for smaller companies.
Right, they can absorb the new regulations, and then the little guys who might be the biggest innovators that could literally cure or save so many human beings are suddenly just beaten out of the market because they can't afford to comply.
Well, and then the larger companies will support the FDA regulations, for example, in order to, because it benefits them and it puts their competition out.
I get that in theory, but pretty much large and small had a chance for 90 days to comment on this guidance, and most people, including our own cavalry comments, they said 60 days. 30 days is probably too aggressive to do it safely and soundly. So when you're a large company, their big issue is they have so many products and so many versions. They don't like that 30 days to do it through their proper quality processes, to Katie's stability point. And the smaller ones, some of them don't have resources. But interesting stuff came in the middle, though, because we always say complexity is the enemy of security. It seems to be the same kind of thing here. Like, they didn't get as much pushback as they thought they would from some of the small folks. And I don't know what the final guidance is going to look like, but I have a pretty good hunch it won't be 30 days.
So I can tell you why the small folks, the little people, don't forget the little people. I can tell you why the small folks, the little vendors probably didn't make a lot of comments. They lack the in-house expertise to divert their attention to reviewing these requirements or these proposed requirements. And they probably are saying, you know what, these aren't final anyway. We'll worry about it when it's final. And that's the resource problem as well. And I've actually encountered this not just in small manufacturers, but in huge manufacturers, especially around I think there's just been a huge rush of legislation and regulation having to do with cyber security. I think there's been a huge, there's been a huge uptick, and this is part of why I took a chief policy officer role at my last startup, was because I was seeing all of this stuff that needed, smart technical people who knew vulnerability disclosure and who understood this industry to participate full time in that type of activity, and it's still quite a lot of a burden. So I'm saying it's not just that they had a chance to comment and they chose not to. They lack the resources. They lack the in-house expertise. It's the same resource starvation problem, but on a human level.
Yeah, we have a super large health delivery organization on the task force and a tiny one. And we have a super large manufacturer like Philips, and we have a tiny one. And they're keenly aware they don't want to produce perverse incentives. I hope that we can pull it off. But on the one hand, I started this chat saying the first mistake we made was of a legislative piece that called meaningful use that really, really put us in a bad position. On the other hand, we're talking about using more legislation or more regulatory to maybe try to fix that. So to me, it's not do you or don't you do something. It's really try to anticipate unintended consequences and measure twice before you cut once kind of a thing.
Yeah,
But
and the middle ground with regulation is really the tricky part, right? It's easy to come up with a regulation that either puts people out of business or doesn't do enough to solve the problem. It's finding that middle ground that is, in this case, in all cases, but especially in this case, very important to the medical community and everyone who's a patient.
And the
But I
one
don't
cost
think-
we
I don't
haven't
think
met.
it's- I'm sorry. Go ahead, Josh.
The one cost we haven't measured yet, and it's actually better to tell the anecdote with cars. But the reason the task force was asked for wasn't because the ransomware stuff had kind of hit yet. The ransomware stuff came a little bit after the act of Congress. It came because they know that we can make new breakthroughs in research and solving cures if we can do even more interoperability and connectivity. And they know that if people lose trust or confidence in this, then we can kiss that promise goodbye.
Yeah.
So there's a project called Precision Medicine, and they want to make sure we're trustworthy enough with our current investment to go the next step to precision medicine. And the best analogy is a car one. The head of the National Highway Transportation Safety Administration starts every speech saying there are 32,675 people that died in the U.S. in car crashes in 2014. And it's up 8% year over year. So do the math. It's about 100 U.S. citizens die every day in a car accident. And that's why he is so aggressively pushing semi-autonomous and autonomous vehicles, because 94% of those deaths were human error and human choice. Now, that's his stance. And what I said to him is, well, why you ignore some of the new hackable risks to this? And he said, well, because I don't want to scare people from something that will absolutely save 100 people a day. I said, that's fair. And if we're cavalier on some of this stuff, the right exotic attack or death could scare the public enough to postpone your dream by 5 years. And he said, oh, that's right. So it's not just, what are the risks in the current time horizon? It's about preserving confidence and trust for the chief medical officers and the patients. Because if we want to start seeing those new cures and new technologies, we can't have people afraid of them. And we're now at an area where the fear is justified and the attacks are increasing.
One of the topics I want to make sure we cover before we have to close out this segment, unfortunately, is, Josh, you mentioned it, is that it seems that medical organizations seem to lack some of the resources to properly staff the security department. I think you specifically called out firewalls and threat hunting and some of the more advanced things that when I talk to financial institutions, they're like light years ahead of the medical community in terms of doing some of these more advanced defensive techniques. Why is it? What economic barriers are there to having this talent in medical organizations, and what can we do to improve that problem and solve that problem?
Well, hold on. Before we dive into the talent problem, which is a universal problem, I want to focus specifically on a medical area safety problem where even the simplest, most built-in security measures that are available to all operating systems that are going to be deployed in these environments that are not deployed. And that's things like a password lockout after 3 attempts. Let's just walk it back. That's not something that you need, an advanced understanding of policy and regulation to know that that's best security practice. Have some kind of password lockout. That doesn't work in a clinical environment because it impacts the usability and safety in an emergency situation. You don't want any of the, if you show the baby picture again with all the machines, you don't want the nurse or the nurses or the clinicians in there. You don't want them sharing passwords, and you don't want them, having to remember their unique passwords for each device, and you don't want them getting locked out. Those are 3 very basic security measures that effectively they have to be ignored in that kind of environment. And
Well,
so,
and the demigods that call themselves physicians and doctors, they refuse. You know, they
but
don't
even if
want to
they,
use passwords at
no, but
all.
even if they, I actually would rather they didn't try to remember a password when they're trying to save my life. I'd
Yes.
actually
No, I
rather
Right.
agree.
that was,
I
And
agree.
everybody gets that. Yeah.
so,
How
but the
many
thing
hours
is,
collectively the folks on the show right now have lost to trying to remember a password?
right, and the
Like
fact,
more than 100 hours, maybe? Show of
Easily.
hands? Yeah, probably.
sure, but I mean, so we're talking about, these more advanced topics of like how do we staff up in that area, and to me it comes down to a usability issue, and the usability issue comes down to a safety issue. So there are contextual things that have to be taken into account when we think about securing, devices that are in a hospital environment, in a healthcare environment. That's just so a point that I wanted to make.
And I think to
Spend all
compound
the money
the
and you're going
problem,
to have patches,
one of
but
the
you're
things
not
that I
going to be able
was
to deploy them all.
one of the things I was researching recently were exploit mitigation technology on the endpoint that supports legacy operating systems such as
Yeah.
Windows 2003. Who can name like one product that does that? Anyone?
Right,
Please make me feel stupid because I thought it was stupid
No,
for not
Emmett,
knowing a
the
product.
Enhanced Mitigation Experience Toolkit, Emmett, it's a free tool. It's released by Microsoft. It's fully supported by Microsoft. You can roll it out, with your systems administration tools,
And
etc.
that will
You can
go
roll it
on.
out with group policy. However,
Mhm.
again, you have to test that
Mm.
and make sure it doesn't
Right.
break anything. You can't. It's not a just 0 to 60. You just turn it on and everything's magical.
Well, that's what
You
people
actually
are
have to
after,
test
Katie.
it.
They just want the magical button I push. And is there like a checkbox for like secure this workstation? Like that's what I want to check. Right?
To me, it's less about us realistically securing and hardening every single one of these beautiful and unique snowflakes because they're all very different. It's more about we had vulnerable exposed software. We had it for a long time. What changed is how hyper-connected we made it with meaningful use. So
Mhm.
it may not be realistic to have really modern, well-maintained, hardened devices throughout the clinical environment. We may need to find more scalable ways to do the segmentation and isolation so that the room, the floor, the wing are less widely open to all comers.
Well,
Like,
that's something we haven't even discussed on this segment is in terms of physical security, how open a hospital environment is. And I was horrified, and I continue to be horrified every time I walk into a hospital for just that reason alone. The fact that I can be anyone in spending, a night or two in the hospital with each of my children as they were born, I would just, freely roam the hospital, and other people could do the same. Everyone that came to visit. And
You're sick, Paul. Nobody does that at a hospital. They just stay where they're supposed to be.
no, absolutely not. And if you talk to penetration testers, they'll tell you about how just easily exploitable that is, the open environment, because
Yeah.
in an average corporate environment, roughly people should be there or shouldn't be there, and people are kind of trained. In a hospital environment, yeah, there's people walking in off the street. That's the nature of the environment, and to me, that's kind of scary.
It's a very unique environment in terms of all the industries that we touch on, I think. Let me ask a really stupid question because you've brought it up several times, Katie
I've
and
brought up
Josh.
stupid questions several times.
No, you've brought up something I want to ask a stupid question about. Is the hyperconnectivity, is the connectivity to so many of these medical devices an absolute requirement, or can some of these devices do their job in terms of patient care without being connected to a network?
Jeff, I know I bust your balls a lot of times, but that was actually a really smart question. Just for the record, I think that was a smart question.
My balls, thank you, Paul.
So the answer to that question is, of course, no, not everything needs to be hyperconnected, right? However, again, looking at the competitive landscape, hyperconnectivity also, in theory, means additional functionality. If you're looking at competing products and one of them does this neat Wi-Fi thing where it will look something up automatically, and the other one says, nope, we're on lockdown, and it doesn't do any of those fancy internet connected things.
Yeah, but you've created a very, very gray area there when you introduce, saving lives versus how can we make more money and sell more.
No, I'm just saying, I'm saying it's not how do we make more money and sell more. It's how does our company survive to have more money to put into R&D to innovate, in saving lives? Well, you have to actually be part of the market in order to compete in the market. And if you're beaten out because you're the most secure thing, I mean, it's VHS versus Betamax. You might have the superior technology, but if you've got no porn, well, you're just going to get beaten out of the market. I know I took it there because, Paul, I figured, I owed you one for that. So
Wow.
Wow.
superior technology does not always win. Superior
You've been on the show a
security
lot,
market
Katie.
does
That
not
might
always
be
win.
the first time you've been on the show and used the word porn. I'm just saying.
This is true. Well, I run my own company, so I do what I want.
Oh, yeah.
I'll do what I wanna.
Are you going to report yourself to your own HR department?
I reported myself. There we go.
All right.
But
That could be considered porn to some people.
there's a lot of scary pieces in the clinical environment, and it's not just to make your cooler thing. A lot of these manufacturers don't want to have the reimbursement tied to mandatory electronic health records transversal. There's this thing called HL7, which is the communication protocol. They all have to speak to be able to transmit electronic health records to each other. And they didn't quite go far enough if they were going to do this, because by making them all talk to each other, but they're not doing it compatible, you can't even do them encrypted most of the time. So you have all this money and time spent on HIPAA and high tech to do the confidentiality of health records.
Well, that's okay, because encryption just invites more hacking.
Oh, of course.
Whoa. He's getting into the next segment.
Yeah.
Yeah, okay.
That was a
right. Relax there.
But,
Speaking of the next segment,
Yeah.
Katie, Josh, closing thoughts. Specifically, what can we do as a security community to help make solve this problem and help make things better with this issue we're talking about today? Okay, Katie, you go first. I'll let the lady go first. How about that, Josh?
I would say that as a security community, I think that we need to be prepared to not just educate vendors in healthcare all across the spectrum on security and best practices. We need to have our ears open for understanding what the actual clinical uses of some of these devices are, understand those trade-offs, and that's the place where we need to learn. So we're not just the sole, purveyors of knowledge and reality in this space. We actually have quite a bit to learn because most of us are not doctors as well as being security researchers. So it's that bidirectional exchange of understanding how things are deployed in the real world, what their intended purpose is, and then putting that into appropriate security context. I think that can be our biggest contribution. We know our security stuff. We don't necessarily know all the medical and clinical stuff, and we need to be prepared to listen to that and modify and work with some of these organizations to come up with viable solutions that are better than what we have today.
Josh?
Yeah, I totally agree. One of the credos we've kind of fallen on, of all the different things we tried, we say safer sooner together, and there's a little Josh Corman bingo card that's circulating around out there, and that's the center square, if I recall. But what we kind of figured out through Suzanne Schwartz, the FDA, and some of the other stakeholders is everything good that's happened thus far happened because it was a multi-stakeholder approach. I think the phrase she uses is whole of community. And you're not just like a pointing finger at past failures. We're kind of trying to take the attitude of being a helping hand towards future success. And we know that we have some partial truths, but they have partial truths. And we're trying to look for all the truths and try to resolve some hard tensions. So that's why I'm encouraged that this task force has 20 very diverse participants. And we're out there on site visiting lots of places. I was just the Mayo Clinic, the #1 hospital in the country. They have the most resources and they still have these problems. And we're trying to elicit discussions from a lot of these folks. And what we noticed is some of these things were just because they were only talking to one stakeholder at a time. We tried a little experiment in December called, again, cyber, but it's called Cyber Med RX. And we did a multi-stakeholder summit where we brought in 25 different stakeholder types, patients, chief medical officers, regulators, congresspeople. And people had heard their tropes over and over and over, but they never heard the other people's. So we gave everyone a lightning talk of 5 minutes to talk about their wants, needs, fears, and what they would ask for and offer. And you had the guy who ran Mass General, for example, explain Katie's point about when passwords are in the way, people die, and how much security people get in the way of saving lives. And he was full of fire and brimstone, and he was absolutely right. And then immediately after him, Marie Moe, who's a security researcher and a pacemaker patient, she got up and she explained how she's very grateful that her pacemaker keeps her alive, and how she feels she has a right to know if it's patchable and what the security vulnerabilities are, and have informed discussions about the risks of her future devices. And you saw him kind of melt because his truth wasn't instead of her truth.
Right.
We had to just put them together. So to me, it's like, I think this approach of multiple stakeholders and trust and ambassador work is why we're starting to turn the page. And that's why there's lots of techniques, and we didn't get to it this week, but maybe we will, but there's lots of techniques for how we disclose vulnerabilities and how we work together. I feel like we're on a trend towards higher trust and high collaboration. And I think it's leading to smarter overall choices. So I'd like to see that continue. And if you're willing, I think I sent you guys a link to a video from our B-Sides track where we had a physician, a researcher, a medical device manufacturer, and the head of the FDA kind of at the same time on the same stage explain at least 4 of the major stakeholder groups in a pretty unified way. And that's where I get a little bit of encouragement. We've got a lot of work to do, but if we work together, we think we can get it done.
Well,
so Josh, you described trust and truth tesseract. That's what you just described. It's a hypercube of trust and truth.
I like it. But now I want some pork sliders.
Well, with that, Katie Mazouras and Josh Corman, thank you very much for participating in this very important segment here on Security Weekly. With that, we're going to take a short break, come back, and do our listener feedback segment. Stay tuned. Don't go anywhere.
Thank you.
Bye, guys.
Bye.
Thank you.
Thanks, Katie. Thanks, Josh.